All right, let's dive right into this explainer. We're looking at a frankly fascinating and incredibly rare postpartum emergency. We're talking about an award-winning scoping review by Dr. Goran Augustin and his team on Vernix Caseosa Peritonitis, or VCP. If you're anywhere near obstetrics, surgery, or emergency medicine, you absolutely need this diagnostic mystery on your radar. So let's get into it.
Section 1. Introduction and Methodology.
So the really crucial thing to grasp here is that VCP, it's not your standard bacterial infection, not at all. What we're actually looking at is a severe, acute, foreign body inflammatory response. It's a reaction to fetal sebaceous material. You know Vernix caseosa, right? That white, cheesy substance protecting the baby's skin in utero? Well, when that spills into the mother's peritoneal cavity during delivery, her immune system essentially panics. It doesn't know what to do with it. Her mature macrophages just can't easily clear out this foreign debris. And the result? The body launches this massive inflammatory response that completely mimics a severe, acute abdomen.
Now, because this condition is so remarkably rare, tracking down solid data is, frankly, pretty tough. The researchers used incredibly strict PRISMA guidelines to filter through the literature. They started with 55 published cases globally, but rigorously narrowed it down to just 46 highly documented cases to actually analyze. And honestly, this gives us the absolute largest, most reliable data set to date to figure out how this elusive condition actually behaves.
Moving on to Section 2, Presentation and Clinical Symptoms.
Okay, what's really fascinating here is how the data completely shatters a long-held assumption in the field. Historically, VCP was thought to be an exclusive complication of C-sections. I mean, it makes sense, right? A surgical incision gives a direct pathway for vernix to spill right into the abdomen. And yeah, sure enough, 87% of these cases did follow a C-section. But here's the wild part. A surprising 13% of cases popped up after vaginal deliveries. The exact mechanism, still up for debate. Maybe it's retrograde flow through the fallopian tubes or a high rupture of membranes. But the takeaway is crystal clear. You absolutely cannot rule out VCP just because your patient delivered vaginally.
When we look at the clinical presentation, those classic signs of an acute abdomen are just glaring. Almost all patients, we're talking 89.1%, present with severe abdominal pain, and over 71% spike a fever. But check out this unexpectedly high rate of respiratory symptoms. Dyspnea, or shortness of breath, shows up in almost a quarter of cases, and tachypnea in about 15%. What this tells us is that this intense granulomatous reaction, it isn't just staying local in the abdomen, it's actually triggering a massive systemic inflammatory response.
Which brings us to Section 3, the Diagnostic Challenge.
And man, this really illustrates the confusion on the front lines. When these patients show up in the ER in agonizing pain with sky-high inflammatory markers, sometimes a CRP well over 200, doctors understandably suspect the usual suspects. Preoperatively, acute appendicitis is the #1 guess at about 15%. They actually guess VCP correctly only 4.3% of the time. Crazy, right? But look at what happens once they scrub in and open up the abdomen. The intraoperative diagnosis flips the script entirely. Over 60% of these cases are confirmed right then and there to be VCP, while appendicitis drops all the way down to 13%.
So, when you're trying to solve this puzzle before taking the patient to surgery, imaging is obviously key. But the data here shows a really stark contrast. Abdominal and pelvic CT scans are far superior. They're concordant or helpful in over 73% of cases, often showing peritoneal thickening or inflammatory fat stranding. Ultrasound, on the other hand, well, it's basically a coin toss. It only agrees with the final diagnosis about 44% of the time. The bottom line, if VCP is anywhere on your differential, this data strongly advocates for getting a CT scan.
Let's move into the OR for Section 4, Surgical Findings and Treatment.
Like we saw earlier, the mystery usually ends the second surgeons open the abdomen. The absolute hallmark of VCP, found in over 41% of cases, is finding these distinctive, white, cheesy exudates just completely coating the peritoneal cavity and organs. That is literally the Vernix caseosa that triggered this whole immune cascade. You're also going to see adhesions in about a third of the cases, and turbid, cloudy, acidic fluid in roughly 26%. Honestly, it looks incredibly alarming, which is exactly why it's so frequently mistaken for massive bacterial peritonitis.
And because it looks exactly like a raging infection, patients are almost always hit with broad-spectrum antibiotics. But here's the critical pivot. Antibiotics do pretty much nothing therapeutically. Why? Because this is an inflammatory reaction, not a bacterial one. So treatment demands a highly structured surgical approach. Step 1.
Thorough surgical lavage. You literally have to wash the vernix out of the cavity to remove the trigger. Step 2. Take tissue biopsies. That's how you spot those diagnostic keratin flakes and lanugo hairs under the microscope. And step 3, which is really gaining traction, is corticosteroids. In cases where steroids were used, patients saw incredibly rapid symptom resolution because you're directly shutting down that hyperinflammatory granulomatous response.
Finally, Section 5, Outcomes and Clinical Conclusions.
But here is the really good news. Despite the delayed diagnoses, the terrifyingly high inflammatory markers, and these severe acute abdomens, the incredibly reassuring takeaway is a 100% survival rate for both mother and baby. The neonates are totally fine. Birth weights are totally normal, averaging around 3.6 kilos, mostly because the condition develops in the mother days after the baby is safely delivered. And for the mothers, as long as clinicians eventually intervene with surgery and lavage, a full recovery is entirely expected, even though things like surgical site infections and prolonged hospital stays are definitely a risk.
So, I want to leave you with this thought. If a postpartum patient, and remember, whether they had a C-section or vaginal delivery, comes in a week later with severe abdominal pain, a fever, and unexpected shortness of breath, could it be Vernix Caseosa peritonitis? As postpartum care continues to evolve, keeping this rare but highly treatable condition on your differential diagnosis radar might just be the absolute key to solving this mystery much sooner. It could literally spare patients from days of agony and significantly delayed surgical interventions. Thanks for joining me for this explainer today, and keep questioning the data.